Tuberculosis of the prostate. Tuberculosis of the prostate is the central point, as it were, of genitourinary tuberculosis. Whether or not the prostate is the site of the original lesion of genital tuberculosis, it is through the prostate that tuberculosis of the urinary tract reaches the genitals and vice versa, and it is through tuberculosis of the prostate that the inflammation crosses from one testicle to the other. Etiology. Those who consider tuberculosis of the prostate a primary lesion, page 580, find its chief cause in chronic gonorrheal prostatitis. Sexual excess, calculus, etc. have been incriminated, and in some cases the disease has evidently nothing to do with previous inflammation. Like other tuberculous manifestations, it is commonest in the young adult of a tuberculous predisposition. I cannot accept infection in coitu. Pathology. Tuberculization always begins just beneath the glandular epithelium. It goes through the ordinary stages of caseation, abscess formation, and fistulization, or it may terminate by cicatrization. Although the tuberculous prostate may show no lesions palpable by rectal touch, the disease is usually bilateral, rarely or only for a brief space confined to one half of the gland. It invades every part of the gland, including the posterior lobe. When abscess forms, it usually bursts into the urethra. I have known but 3 to open posteriorly. The tuberculosis spreads to the posterior urethra and bladder. Symptoms. The disease begins in one of 4 ways. 1. It is secondary to a chronic posterior urethritis, assuming its specific characteristics imperceptibly, and patient and surgeon are often unaware of the change until rudely aroused by some of the typical manifestations of tubercle in bladder or epididymis. 2. It is apparently spontaneous. The patient comes complaining of gleat or dysuria, for which he fails to account. 3. It is a minor feature of an epididymal infection. The patient complains of the enlarged testicle and is not aware of the shreds or pus in his urine that testify to the prostatic inflammation. 4. Less frequently, a spontaneous hematuria or a urethroragia is the first sign of the disease. The prostate may be tuberculous for many years and yet give no symptom. When symptoms arise, they are due to ulceration of the posterior urethra and bladder neck and are precisely those of tuberculous cystitis. Diagnosis. Until periprostatic suppuration burst and leaves a rectal or perineal tuberculous fistula, we have no pathognomonic clinical sign of tuberculosis of the prostate. When the epididymis or the bladder is known to be tuberculous and the prostate found to be swollen or nodular, we conclude properly enough that it is the seat of tuberculosis. But in the absence of these adjacent lesions, the prostate itself gives no characteristic sign of the disease. It may be tuberculous and yet show no palpable change. It may be indurated in an irregular manner, suggestive of tuberculosis, and yet not be tuberculous. The prostate, like the epididymis, is subject to acute non-gonorrheal infection, very suggestive of tuberculosis, from which indeed it is usually distinguished only by the absence of the tubercle bacillus and the spontaneous cure of the acute prostatic infection. Prognosis and treatment. Although prostatic tuberculosis may protract the duration of bladder tuberculosis after the removal of the offending kidney, this type of tuberculosis, nevertheless, usually gets spontaneously well under hygienic treatment. The usual type associated with unilateral or bilateral tuberculosis of the epididymis and seminal vesicle may be depended upon to get well with epididymectomy and hygiene. Exceptionally, however, the prostatic and vesicular lesions persist and cause grave stricture of the urethra, periurethral abscess, and persistent tuberculous cystitis. Under these circumstances, operation is justifiable with the object of removing the seminal vesicle and more or less of the prostate. This operation is justified only by persistent and intractable lesions. It may result in a brilliant success, but is rather more likely to result in large tuberculous perineal fistula with complete incontinence of urine. Sufficient experience has not accumulated to determine whether in these desperate cases it is wiser to perform this operation or ureterocolostomy.